Thank you very much, Larry. I'll get back at you later. I'd like to thank the Foundation for inviting me to talk about ultrasound guidance. I feel a bit as though I'm being thrown to the wolves here. To talk about ultrasound guidance of HIFU at an MR-guided symposium is probably the worst spot to have. The symposium gave me a title, which was the comparison of MRI and ultrasound guidance for focused ultrasound. I've taken the liberty of saying I'm not going to talk about that. Instead, I'm going to try and convince you that ultrasound guidance of HIFU has its merits, as well as MR guidance. Many of you may be surprised to know that ultrasound imaging has come a long way, and state-of-the-art ultrasound imaging looks really quite similar to state-of-the-art MR imaging, I think. And I've shown here, I've taken an example from the Philips website, where on the left you have an MR image, and on the right you have an ultrasound image. And I think you should agree that the ultrasound image is really pretty good. It's showing anatomical features pretty clearly. HIFU we talk about as being a new technique, but I think many of you will be surprised at the numbers that are on this slide. For another talk I gave, I asked manufacturers how many patients had been treated with their systems, and if you top those numbers up, it comes to something short of 900,000. Well, as you can see, most of that 900,000 is the 800,000 from the cervicitis treatments from the Chongqing HIFU Superstar system, which is ultrasound guided. But of the ones that we really are more concerned with here, the prostate cancer, the abdominal tumors, the bone tumors, the uterine fibroids, the vast majority of those, of course, have been done under ultrasound guidance. About 10,000 of those have been done with MR guidance, maybe a bit fewer, but the rest have been done under ultrasound guidance. So like it or not, ultrasound guidance is out there, and it's helping to further the spread of HIFU into clinical practice. A recent paper published by the Milan group, Franco Orsi and his colleagues, I think shows you just how successful ultrasound guidance can be. The topic of the paper was the HIFU ablation of tumors in difficult locations. Like many of these studies, the population is very small. There were 38 tumors in total. But you can see that they were treating close to critical targets. Their treatment times, up here at the top, were less than 2 hours on average, in most cases, although with the pancreas it was a bit longer. And if you look at the survival curves below, on the left you've got the recurrence rate for liver metastasis. In the center you've got HCC patients, and on the right you've got pancreatic cancer. So there is clinical evidence out there for ultrasound-guided HIFU as well as MR-guided HIFU. What do we ask of an image guidance system when we're doing these ablative treatments? Well, we need our image guidance to target the treatment volume and to monitor the ablation. And when we're choosing our modality for doing it, we want to look at how well it visualizes the target volume, and especially the boundaries of the tumor. We want to visualize the critical structures near the target volume. We also want to be able to visualize the tissue in the acoustic path, and it's important to remember that we not only want to look at prefocal structures, we need to know what's happening postfocally, because the sound doesn't stop when it's got to the focus. It goes on, and if you've got the spine or something else behind, you need to make sure you're not doing any damage there. And importantly, you want to visualize any changes during treatment, either focal or non-focal. You need good spatial resolution for targeting accuracy, and also for monitoring your tissue changes. And when I say monitoring tissue changes, I'm not only concerned with what's happening at the focus, I want to know what's happening, for instance, at the rib cage if you're doing liver treatments. And you need good temporal resolution so that we can accommodate tissue motion and we can do our treatment monitoring very accurately. If you compare the spatial resolution and the temporal resolution of ultrasound and MR, you see that spatial resolution really isn't very much different these days. And the temporal resolution also isn't much different, although we in ultrasound imaging think of ultrasound as being truly real-time and MR imaging as being quasi-real-time. When we're looking at side effects and complications, we want to know whether there's any scar tissue that we're going through, because we know that scar tissue absorbs the sound highly. Is there any bowel in the path? We don't want gas in the way. Are there any ribs? It's the bone problem. What's your path length? And you also need to know, for instance, if you're treating radiotherapy failures, whether you have poorly vascularized areas of tissue which might heat more than others. So, let's talk about the strengths of ultrasound. Ultrasound scanners are small and they're readily available, and they're relatively cheap compared to MR scanners. If we look at some of the commercial systems that are available, on the left you've got the new Chongqing HIFU device, the JC200. It's not exactly small, but it's not the size of an MR scanner, so it's the size of a treatment couch. Top right, you've got one of the two transrectal prostate devices. This is the Sonoblate. The Ablatherm looks very similar. So these are small, and when you've got a space-poor hospital, such as we have in the UK, where space is always a premium in our hospitals, it's good that you've got small systems that you can tuck away in a corner and wheel out just when you need them. And bottom right, we have the new system, the Thoraklion system, which is a thyroid-specific HIFU application, which is ultrasound-guided. With ultrasound, you get a real-time visualization of the beam path, and one of the nice things about ultrasound is that the imaging beam follows the same path as your therapy beam. So broadly, if you can see it with on an ultrasound image, you can probably get to it with your therapy beam. Because you have very good real-time imaging, you can do speckle tracking-based algorithms to compensate for motion, and you can do image registration. And one of the things that we can do really well with ultrasound imaging is blood flow monitoring. You can do this using either microbubble contrast agents, or there are new systems now which will allow you to do really sophisticated blood flow imaging without contrast agents. And this is the new eFlow system from Aloka. And I think you agree that those are pretty amazing images of the capillary system in the kidney. Ultrasound can't do everything, of course. No imaging modality can. It has its weaknesses. We rely, for saying that we have ablation, on having hyperechoic regions in the tissue at the moment. That's the clinical endpoint that's being used with the ultrasound-based systems. It's not 100% reliable, and we know that when we get the hyperechoes, we have boiling in the tissue, and so we've overtreated. So it'd be nice to be able to have a monitoring system that allowed us to reduce our power so we don't have to overtreat in that way. Currently, we don't have clinically available ultrasound thermometry. I think we will have it, but it's not available on any of the clinical devices. You do get image degradation during treatment because as the temperature goes up, the speed of sound changes, and the ultrasound imaging device assumes a constant speed of sound, and so you get degradation of your image. And of course, we can't image behind bone or gas. But what can we do with ultrasound guidance now that's good? Well, we can show the acoustic beam path, and as I said, that's a nice thing about ultrasound guidance. It's following the same path as the therapy beam. You can see where boiling has occurred. That's where you get the hyperechoes. You can allow the use of your breathing to, if you've got a tumor that's hiding behind a rib cage, using real-time ultrasound guidance, and I'll show you this, you can move the tumor into the intercostal space. And you can show the local blood flow. So let's look at some of these things. This is a 69-year-old patient with lymph node metastases in the hepatic hilum from colon cancer. You can see the scan pre-HIFU, and this is the HIFU during treatment. And you can see in the right-hand image that bright up, that echo which we use to say we've got ablation. And post-HIFU, you can see the ablated region. So that looks very similar to the sort of things that you see if you've done MR-guided HIFU. Here you can see a liver treatment, a tumor very close to the IVC, and you can see that with ultrasound guidance, it was possible to treat right up to the margin of the IVC. And if we look at the pancreatic treatment here, we have a PET-CT image prior to HIFU. You can see the ultrasound image prior to the HIFU treatment. And there you can see the bright-up that occurred during the HIFU treatment of this pancreatic cancer. And here is the PET-CT image after HIFU. Now, ultrasound doesn't go through bone, so where you have ribs in the way, you will get shadowing, and that can be seen very clearly here. This is a tumor we treated with the Chongqing system in Oxford. You can see here the tumor. Here's the shadowing from the rib cage. See the bright region where we've done some ablation. In this case, the tumor was nicely spaced between the ribs, so we had a very nice intercostal window. But if the tumor is tucked behind the ribs, as in this case here, you can see here's the rib cage, casting shadows. You can see half of the tumor here. Whoops. By controlling the patient's breathing, you can move that tumor into the intercostal space. And I hope you can see that here we've got, this bit is completely masked, and here we've still got a bit masked, but we can treat a bit more of the tumor. And that's a nice thing to do under real-time ultrasound guidance. We can use Doppler ultrasound to see where are the big blood vessels in the treatment region, and specifically try to ablate those regions before going on to ablate the whole tumor volume. One of the things that I think ultrasound is very useful for is because it's so real-time and because you're watching the images all the time during treatment, you can watch for side effects. And one of the things we sometimes see are near-field tissue changes. Here you can see a tumor that's being treated, and what we're looking at here are the changes in echo pattern in the near field, so prefocally. And as you can see, as we go through time in doing our treatment, that if you compare this with this, there have been near-field changes, and as soon as we see those near-field changes, we stop the treatment, or we move to a different slice. And in many ways, we watch the near-field much more closely than we watch the focal region, because that's what's going to cause the adverse events. One of the things, as I said, that we have a problem with is that sometimes we lose the tumor during treatment. So here you can see a tumor that we're treating. You can see the margins quite well on the ultrasound, because with ultrasound imaging, the moving images are much easier to see the feature than the stills. But here you can see the tumor quite nicely. But during treatment, you've lost the tumor. It's not because we've cured it, it's because the speed of sound has changed and we're losing the image. Once the tumor has cooled down, or once the overlying tissue has cooled down, you see we regain the tumor there. So that's something that a challenge that we have with ultrasound guidance. So the question is, what will ultrasound guidance be able to do in the future? Here's what we do at the moment. This is an HCC that was treated in China. You can see the region outlined. If you compare this slice with this slice, you see how the region's been painted out with our bright echoes, showing that we've got confluent ablation. But it's not always easy to get, so what can we do? Well, of course, we'd like to do thermometry, and because the speed of sound is temperature dependent, you can get displacement images, and from that you can get temperature images, and this is some work we've done at the Institute, my student John Chivale, and here you can see that we can show for a sighting shot, so to tell us where the focus is, we can look and see where the heating distribution is along the axis of the ultrasound beam. And one of the nice things about that, and this was alluded to, I think, in Kim Butts-Pauli's talk yesterday in one of her questions, is that if you can get a nice focal spot of temperature, and you can very rapidly, as you can with ultrasound, get a heating and cooling curve, then the peak, the amplitude of that heating curve will tell you what the local absorption is, and the cooling curve will tell you what the local vascularity is, what the local cooling is. So you've got a lot of information, local information about the tissue. And this is very nice work that's been presented by Imad Abini from Minneapolis. Okay, so we're not very good at measuring temperature at the moment with ultrasound. What are the tissue properties that change with ablation? Well, we know that the acoustic attenuation coefficient changes. So if you can map acoustic coefficient, if you can map the attenuation coefficient using, for instance, reflex transmission imaging, then that will tell you about ablation. We know as you cook tissue, it gets stiff, so you've got the possibility of elastography, and the vascularity will change as well. So let's look at elastography. Nice thing about high-intensity ultrasound beams is that you get a radiation pressure force. So we have ARFI. So you can use the HIFU beam to produce that movement, and we had a talk about MR ARFI yesterday, but ultrasound ARFI, of course, is a well-developed field. And you can see here, this is the lesion here, and you can see the strain image here of cross-section. And as Michael Tonterre has told us, and Matthijs Vink told us yesterday, we can use shear wave imaging. So here we have the ultrasound, this is the supersonic imaging system, looking at a lesion. And here you can see on the left, pre-HIFU and during the HIFU monitoring, you see the shear, the elasticity map during treatment. And again, Michael showed this morning. This is work from Eddie Lean at the Hammersmith in London. This is RF ablation, not HIFU ablation, but here you can see on the ultrasound image, you can see the RF electrode coming in, and you can see the ultrasound image, but on the top you see the shear wave elastography, and during the heating you see that region getting bigger as the ablation increases. And I think that's a very exciting possibility for monitoring HIFU during ultrasound guidance. Matthijs also said you'd be able to do thermometry. Here you can see, again, this is work from Michael Tonterre, you see the shear modulus as a function of temperature. It's different for different tissues, but maybe this is something that we can use for thermometry. And they have very nicely shown that the shear modulus change is linked to thermal dose. We can also, of course, monitor cavitation with ultrasound. We've done some work with Ron Roy and Caleb Farney, a student of mine, using an ultrasound scanner where here you can see a lesion that was produced in tissue, and here you can see the acoustic emissions developing over time, and you can see that when you start to get cavitation, you get the acoustic emissions, and so you can get a cavitation map in space and time. So just to sum up, what other than the bright echoes, what else can we use for ultrasound treatment monitoring? Well, we can use elastography, and for that we can use either the imaging transducer or a therapy transducer. We can use backscatter thermography. We can use transient echoes, the bright echoes we're using at the moment, and we can use cavitation monitoring for looking at our treatment. So the disadvantage, just to sum up, the disadvantages of ultrasound: we can't image behind burning gas, we can't yet do thermometry clinically, and one of the problems with ultrasound imaging itself is that you get beautiful images when you have the transducer on the skin surface, but as soon as you have to have a water standoff, the images are degraded, and that's something that we need to get the imaging manufacturers to address. The advantages: we have good spatial and temporal resolution, the propagation path is the same for imaging and therapy, we can have real-time monitoring of the acoustic window, and there are lots of new things coming up. So in conclusion, I think the best method for monitoring our HIFU treatments is likely to be application-specific. And in our labs, we're looking both at ultrasound monitoring of HIFU, but we're getting very interested in MR guidance as well. And I think they've both got their role to play in getting our HIFU techniques out into the clinical community. Thank you very much.
Questions? Yes. I knew if I waited long enough. Neil wanted to ask a question.
Would you speculate as to which application or indication MR guidance would have unique value?
Certainly in the brain. There's absolutely no question about it as far as I'm concerned. The ultrasound imaging of the brain is a long way off being a reality.
can I assume that the temperature monitoring is a kind of an option if we can monitor the coagulation process properly?
My feeling is that we don't have to have temperatures at the focus. If we can do elastography at the focus, and we know that that correlates well with our ablation, that's fantastic. The problem is for the adverse events that you're looking for. So you probably need to monitor something else at the skin surface over ribs. And maybe that has to be temperature at the moment, maybe it can be something else. But certainly you do see very subtle changes in speckle when you start to get overheating, you see them on ultrasound guidance. Whether that should be temperature or not, I wouldn't like to say.